Hi, everyone. Welcome to our multi-heart lecture series. It's a great pleasure to be here with everyone again. We have today Dr. Pradeep Natarajan that will be presenting on polygenic risk scoring for coronary artery disease. Pradeep is a real superstar in prevention. If you don't know him yet, I don't know where you've been, but he is the Director of Preventive Cardiology and the Paul and Phyllis Farman Endowed Chair in Vascular Medicine at Massachusetts General Hospital. He's also an associate professor of medicine at Harvard Medical School and associate member of the Broad Institute at Harvard and MIT. Dr. Natarajan received his BA in molecular biology from the University of California in Berkeley and his MD from UCSF. In addition, he had a master in science in biomedical informatics from Harvard Medical School, where then he did his internal medicine residency at Brigham and Women, and then his clinical and research fellowships at MGH. He leads several consortia to use genetic epidemiology, large-scale sequencing studies, genotype-driven human investigation, and genetic test implementation. Among his scientific contributions, he has led human knockout discovery and investigation to prioritize therapeutic targets, monogenic and polygenic characterization of heritable traits through whole genome sequencing, and the novel concept of somatic mutations contributing to cardiovascular disease. He has authored over 600 scientific papers, including senior author publications in Nature, Nature Medicine, Nature Genetics, JAMA, JACC, and Circulation. He's an associate editor for JAMA Cardiology and Science Advances. And on top of this, he oversees clinical and training programs on the prevention and cardiometabolic diseases at MGH. So it's a real honor to have you here. Thank you very much for taking the time. I'm very excited for your lecture.
Great. Thank you so much. Thanks for the wonderful introduction. I'm delighted to be with you all. So start going through my disclosures. And just to give you a high level of just the various things that we do is we really use genetics as a tool primarily to understand cardiovascular disease. And these are approaches that were really only possible over the last 10 to 15 years, now that we have large-scale data sets where we have labeled individuals who have cardiovascular disease and those who don't, and then understand how naturally occurring human genetic variation in the population influences that risk. And it's a very powerful tool for causal inference because these are biomarkers that are stable from conception and onwards, unlike other biomarkers that you may look at clinical outcomes that change across the life course, which still may also be important. The genetics can be a very strong anchor in providing causal inference because confounders are not going to be changing the allocation of those alleles and the stability over time. So we use those tools to really help us understand why humans get cardiovascular disease. A traditional approach, which is still, a very popular approach, obviously, is to do, to generate experimental models of genetic perturbations and then see what happens in the experimental models. But ultimately, we're most interested in understanding what's relevant in humans. Now, one can take all of that information together, even without knowing mechanisms, to really also to develop risk classifiers. And so that is, one application of using genetics in cardiovascular disease, and has emerged this concept of polygenic risk scoring. So, not too long ago, we put out an American Heart Association scientific statement about this, even though this, field is still pretty new. But there was enough that general cardiologists and the public were getting exposed to, and lots of motivations to try to start to understand individuals' genetic predisposition to cardiovascular disease, what the current evidence was, what the limitations are, and what the opportunities. And, it's very unique for something like genetics and genetic risk prediction is that this is a major motivation for why many people do participate in direct-to-consumer genetic testing. It's not the only reason, but, in many of these surveys, people describe this as one of the motivators. And increasingly, in the US is already an outdated slide. There are, tens of millions of individuals out there who have participated in this. And increasingly, many of these companies are returning risk scores. And this is very unique as far as biomarkers related to cardiovascular disease risk, because As far as, lab tests, the other, what we have used for decades is blood lipids. But there's no place that you can go to on your own and get your blood lipids checked without at least the authorization of your doctor. But here, for a very novel biomarker, one can just go out there and then bring it back to the doctor's office. And in those scenarios, there's no clear guidance exactly what to do. And so part of this document was to help us understand. And it's not just through direct-to-consumer testing. There are, many of us that are ascertaining very large research cohorts of individuals labeled as having cardiovascular disease and others. And to try to understand the genetic architecture for coronary artery disease, but that in turn has actually led to even more, millions of individuals that also have genetic information, meaning these are opportunities to understand risk and to reduce risk in these patients. What has changed, I'd say, over the last, 5+ years or so, is that many of these data sets are being generated within healthcare entities. Now, this was published fairly recently, but is already outdated because many of these cohorts are larger. And some of these are national efforts. Most of these in the US are spurred by healthcare entities, where many individuals are receiving care. There is also a generation of this exact same genetic data. And so that provides a separate opportunity, something that could be opportunistic. And you'll recognize that these are all entirely separate from just ordering this as a clinical test. And we'll talk about all of these scenarios, but that represents a very unique opportunity here that is not available with the wide variety of biomarkers that are being assessed for cardiovascular disease. And hence has spurred this interest in trying to understand how we should, responsibly start to think about this. As an example of our own biobank, and it's a really unique opportunity with these healthcare-associated biobanks to understand a wide variety of the drivers of disease, which obviously it's not only genetics, but genetics can really help us learn a lot about our patients. This is an example. We took all the genetic information and then identified genetically similar groups that we can map back to reference populations. Actually, many, not all populations participate in these reference data sets. So we actually uncover a lot of groups that are not well represented in the human genetic data, but we can map up exactly to where people live. And we can describe, really unique phenomena. This is an example. Cluster 0 is basically the most common group of individuals that are within our biobank in Mass General Brigham, which are individuals of British ancestry. And you compare that to individuals who live in the UK, and you see this funny little dip that actually represents a bottleneck of around the time of the Pilgrims that you can track back to this. And you can see, various different bottlenecking effects, other, forms of admixture, and we start to understand the important social constructs and environmental constructs is how we start to understand this. So it is very, very early phases, but as we think about precision medicine, much of this has anchored to start on genetics. Now, genetic testing so far for cardiovascular disease has largely been for diagnosis. A patient who comes in with a symptomatic condition, trying to understand the root cause of that condition. And then that helps with establishing whether it's a Mendelian cause, a rare genetic cause. And in some scenarios, if a proband, an individual is symptomatic, has a positive genetic finding, then you can take it to other asymptomatic individuals to see if they may be at risk for future disease. But in general, it is not a common paradigm, not really a paradigm to do genetic testing in asymptomatic individuals. Now, for coronary artery disease, which is kind of the focus of this talk and what I think about most, genetic testing has been around for a long time. It's focused on familial hypercholesterolemia, an abnormal risk factor, very high cholesterol, which then predisposes to premature coronary artery disease. But still, if there's genetic testing, it's for that diagnosis. But it's been very controversial, and still is today, on whether one should even do genetic testing for FH at all, because you have a readily accessible biomarker in blood lipids that often strongly clues you into whether somebody has FH. So not immediately clear, at least for many years, why you would want to know or need to know that it was a strong genetic driver. Most of the mutations that have been described to date are in the LDL receptor, the receptors that sit at the surface of liver cells that are responsible for binding LDL particles and basically bringing them back into the liver. And so these patients generally have disruptions in that LDL receptor. So the LDL particles stay in circulation, and in turn, the liver thinks that there isn't that much LDL because LDL particles are not coming in. Cholesterol is not coming in via LDL, and so HMG-CoA reductase, rate-limiting step in cholesterol synthesis, is upregulated, so even more cholesterol is produced, and it's this kind of vicious cycle. What has changed is that now we are generating larger data sets of unselected populations to really understand what is the complementary role of genetic testing and lipids. And I know the topic for this talk is polygenic risk scoring, but it's important to compare to what we do today, and at least within the scope of coronary artery disease, to understand how we might think about polygenic risk scoring without introducing dramatically new paradigms yet. So it turns out, for individuals who have hypercholesterolemia, if you have hypercholesterolemia because of an FH mutation, that substantially escalates your risk over and above just what is anticipated just from the lipids alone, suggesting that there's, in addition to helping us understand why individuals had severe hypercholesterolemia, it does further discriminate their risk. They do represent only a minority of individuals who have severe hypercholesterolemia, only about 1 in 50, but those folks are at particularly high risk. Now, today, for everybody with severe hypercholesterolemia or FH, we treat them with statins, but in the world, it's variably recognized and variably treated. And in a retrospective analysis, one can go back and just see, understand how prognosis changes and improves when patients with FH are given statins versus not. Now, an interesting observation, again, in a retrospective analysis, is that there is a greater relative risk reduction for individuals who have FH compared to those who don't have FH. What that means is that for the same amount of LDL cholesterol lowering, individuals with FH have a greater cardiovascular disease benefit. And that's not an expected observation, because if you look at randomized controlled trials for statins, the relative risk reduction is roughly about 20 to 25%. So hazard ratio of 0.8 to 0.75 for about every 40 milligram per deciliter lowering for of LDL cholesterol. This suggests that it's much greater, implying that if you knew that the mechanism was FH, not only should they be on statins, but you should be maximally aggressive, because in the end, we care about counseling individuals about risk, but we care most when we say, okay, there's a therapeutic regimen and you're more likely to benefit from that therapeutic regimen. Okay, now the vast majority of individuals and the population, or even those who get cardiovascular disease or premature cardiovascular disease, don't have FH. It's about 1 in 300 individuals, but cardiovascular disease is very common. I should have updated it with the 2024 AHA statistics that was published just this week, but it's basically unchanged. Cardiovascular disease remains the leading killer in the US, and then over the last 20, 30 years in the world, primarily due to ischemic heart disease. And you may look at this graph and say, at least it's not continually going up. And that's true. Around the mid to late 1960s, this is a really strong recognition of modifiable risk factors over the course of time, understanding their role in the pathogenesis for cardiovascular disease, but widespread appreciation, including the Surgeon General's report on smoking and others, have prevented this from going over. But, most of ischemic coronary artery disease has really been a phenomenon really that started in the 20th century, as other cardiovascular disease conditions like complications of hypertension, rheumatic heart disease that were issues before. So this is relatively new. And this was, among the reasons why things like the NHLBI, before it was just the National Heart Institute, and others were formed. So anyway, like you see again over the last 10 years that maybe these are coming up, but it still retains this distinction of being number one and has certainly not come down. Now, as things are more expensive, there are more people, individuals are living longer, even though this curve is flat, the cost related to cardiovascular disease goes up. Obviously, in a room full of cardiologists or trainees in cardiology, I don't need to sell you on the notion that cardiovascular disease is important. However, the things that we do today are not sufficient to basically address the number one public health killer in the US. And what we've been doing has basically been the same since the 1960s and 1970s. This is, seminal paper on describing risk factors in the Framingham Heart Study, blood pressure, cholesterol, cigarettes, blood glucose. And today, the pooled cohort equations, and pretty similar still with the prevent equations, we're using the exact same risk factors. We just understand a little bit more for the weights. Major challenge with this approach is, we have focused on, and because the research infrastructure is focused on this, is that we've focused on intermediate term risk to identify individuals at risk. So what's the likelihood that they're going to get cardiovascular disease over the next 10 years? And the challenge with this approach is that regardless of a risk factor, individuals who are younger will always calculate as low 10-year risk, and individuals who are older will always calculate as high 10-year risk. And the sweet spot is middle-aged, right? And this is just the panel on the right is just a mathematical exercise of just binning individuals by different deciles and saying, as the risk factor goes up, how does the estimated risk go up? And as you all know, it's not like atherosclerosis starts overnight, right? But through this approach, we're not identifying the individuals who are ultimately at risk later in life for cardiovascular disease. We're basically uniformly undertreating individuals who are going to go on to develop cardiovascular disease. Now, there's pretty good literature in helping us identify or understand, or at least validate the notion that this does not happen overnight. These are autopsy data from U.S. soldiers that are killed in foreign wars. This is an amalgamation of Vietnam, Iraq, and Afghanistan wars. And the prevalence of cardiovascular disease risk factors has changed over time. Largely, the prevalence of smoking among U.S. soldiers continues to go down. But you see that there is actually, large fraction of them that have atherosclerosis. Vast majority that have atherosclerosis don't have risk factors. It's, about 10% have atherosclerosis, right? But we don't, their 10-year risk, all of them, regardless of their risk factors, will all be low, right? So the current 10-year risk model is not sufficient. Now, in the population, there has been a suggestion that, when people get premature cardiovascular disease, that genetics may actually play a strong role. This is an analysis from the Framingham Heart Study, where if you look at individuals who have had parents with premature cardiovascular disease or siblings with premature cardiovascular disease, they are more likely to get premature cardiovascular disease themselves by about 1.5 to 2-fold, right? And this is all independent of the traditional risk factors because for many of these families, the familial risk is closely tied to traditional cardiovascular disease risk factors that may be heritable or others. So this forms the hypothesis that there may be important independent genetic factors that are leading to this increased risk that we're not otherwise observing. Okay, and that has led to these, genome-wide association studies for a wide variety of traits, but including for coronary artery disease. And as I said in the beginning, the basic experimental approach is you take large groups of individuals and label who has coronary artery disease and who doesn't, and you systematically profile their genomes similarly. And then you look systematically for each of the alleles, if any of the alleles are enriched among cases versus controls. And those that are significantly enriched are the ones that clue us into gene regions that might influence coronary artery disease. As I said, we spend a lot of time thinking about mechanisms. It is really hard to unpack those data for mechanisms because even though they clue you into important gene regions, they're often in regions that are in between coding sequences in potentially some regulatory area. So it usually is not immediately clear what the gene is or how the variant is influencing the gene. This attempts to, kind of map to traditional risk factors of what we know about cardiovascular disease to say, okay, this is maybe how some of these gene regions are influencing cardiovascular disease. But, vast majority, we actually don't have a prior clue on why they influence coronary artery disease. We just have a strong now empiric observation that they do. It's actually a fair amount of work to unpack this. But as I said, regardless of mechanism, we can still take all of that data together to build a risk classifier. In its simplistic form, you could just then go to the patient and, profile their genome and say, okay, among all of the regions that have been associated with coronary artery disease, the alleles that are enriched in cases, how many of them are they enriched in that patient? This is the earliest iteration. It was only about like 12, 13 years ago. Since then, they have advanced to being weighted scores because now we know that there is a differential relative enrichment of some of those alleles. Some of them are, 20% more enriched. Some of them are 50% more enriched. So you can weight each of those individual alleles. And then as we know, as you get larger and larger genome-wide association studies, you have more and more confidence in many of the regions, and you discover more regions that are associated with coronary artery disease. So there are new Bayesian methods that actually can use the totality of that information to kind of predict other regions that are likely to also influence coronary artery disease. And in the end, it's very similar to building any other risk score where you do additional training of some of the parameters in one data set and then you validate in another. And this is not unique to coronary artery disease. Here's an example of a range of genome-wide association studies for all the common cardiovascular diseases that we see, and they all have heritable bases. And we are learning a lot about what are the new mechanisms, unappreciated mechanisms, as well as validating known mechanisms that influence human cardiovascular diseases. And this can be done for any trait. Also means that one can develop a polygenic risk score for any trait. Among all of the cardiovascular disease, most of the studies that are evaluating the clinical applicability and utility have been in coronary artery disease to date. But, over the years, you all will read more and more studies, and there are in the literature for polygenic risk scores for these other conditions. Okay, so as I said, family history is what clued us into the relevance of genetics. So is there a role of the polygenic risk score if somebody says they have a family history for cardiovascular disease? Now, there is, and it's surprising that there is. I think you can glean a couple observations. So one, a polygenic risk score is higher among individuals that have a self-reported family history for cardiovascular disease. And you can see, and this is one of the older scores, for individuals who have a family history or not, a polygenic risk score is stratifying their future risk for cardiovascular disease. And this helps us understand that, when people have a family history for cardiovascular disease, it's complex. Genetics plays a role, but it doesn't only capture genetics. Individuals who, grew up with certain family members, they often tend to, live in a similar area, tend to often have similar incomes, similar educational opportunities, similar lifestyle practices. So family history is capturing a lot of information, and this specifically refines what is the quantitative genetic contribution. Because in the end, as I said, so lots of different markers, in the end, you have a singular marker, and that's a continuously distributed score. This is from the UK Biobank. This is one of these national biobanks I showed on the slide. This is an earlier release. Now is about 500,000. This was about 150,000 individuals. And then how does it stack up to clinical risk factors? As I said, for 10-year risk, you get most of the way from age and sex. When people talk about like C statistics, which is a sense of how often is a biomarker present or abnormal in individuals who go on to get disease, and how often is it normal among individuals who don't go on to get disease. So the C statistic will give us some sense of how that model has improved beyond age and sex. And so, 0.5 is flipping a coin. And you can see how all our traditional risk factors perform. I think people lose sight of what the benchmark is. Now, a genetic risk score is similar, if not a little bit better. Obviously, we don't just use these in isolation, so this is what it is together. And then again, by this exact same metric, this is providing us, the genetics is providing us more information through this specific metric. This is one of a variety of metrics to evaluate the performance of a score. Now, another metric is looking at the effect estimate, just how often or what is the relative increase when individuals have abnormal polygenic risk score for likelihood of having cardiovascular disease. This is represented on a continuous scale because I said it's a continuous score. So per standard deviation, what is the relative increased risk? So one, this looks at the healthcare associated biobanks, so ours in Philadelphia and in Mount Sinai. And, regardless of, where and exceptional tertiary care academic medical centers, and maybe we're somehow gleaning this information, but no, that's not the case. This is still capturing a large risk signal and potentially a risk opportunity in our patients, and very similarly across geographic contexts. Now, individuals with FH, as I said, have high LDL cholesterol, but individuals with a high polygenic risk score have a small, but clinically small increase in LDL score that you would not be able to detect or reliably, confidently say based on somebody's lipids. Like the increase is about like 5 milligrams per deciliter, and high I'm defining as the top 20th percentile, so 1 in 5 individuals. And then if you look at, we said that there is a risk signal. So are they generally more eligible for statin therapies? Or are we just somehow missing them? But no, that's not the case. If you look at the distributions of their calculated 10-year risk scores, again, by the pooled cohort equations, you're not identifying individuals through this approach at high genetic risk, even though empirically they have a higher future risk for cardiovascular disease. Now, motivation for doing this was also because kind of around the same time we were doing this was the prior cholesterol guidelines, now advancing a new concept called risk enhancing factors, saying beyond the traditional risk factors, these are factors that are about present and that are increasing risk by roughly 1.5 to 2-fold. This may help refine risk for some patients, or at least increase or strengthen recommendations for statins. And so, and these are all been shown just by epidemiological studies, not like randomized controlled trials. So say, let's benchmark to that. And so, individuals at the top 20th percentile have at least 2-fold or so increased risk and are complementary to traditional risk factors. And so we said for individuals in the middle, because these are healthcare settings, so we can see exactly how they're managed, maybe we're just already putting these folks on statins, maybe there isn't an opportunity. And you kind of cultivate that down to say, okay, high sort of borderline intermediate risk, high genetic risk score, not on a statin. In the end, we anticipate that, maybe about 4% of individuals would, we'd newly recommend a statin through this approach that is well harmonized with the current kind of like 10-year risk framework. A major barrier or major limitation in polygenic risk scores in their current form is because any risk score is influenced substantially by what the training data is. The vast majority of training data for genetics, and to be honest, most of the biomedical literature has been in European populations. This represents kind of over time, just the accumulation of research genetic data from populations. The red is Europeans, and this is the current distribution of European ancestry and other ancestry. So others, largely dwarfed. As a result, a polygenic risk score for anything, this is actually multiple polygenic risk scores together, will always be, relative to Europeans, worse relative to Europeans. And it's not because Europeans just have more genetic disease or these traits are more heritable. A lot of this is a function just of how these were derived. And these are, important because, as I said, in the biomedical literature, this is also a major issue. Like much of the literature has been generated in one group and not necessarily in others. And we assume that these have translatable insights. But this has actually been empirically evaluated in genetics, and we see that this does influence the performance of these scores. Now, there's been lots of endeavors in trying to improve the, that graph and trying to get more of the non-Europeans. The US-based effort is the All of Us research program. Started, President Obama's State of the Union address in 2015, where he talked about the precision medicine initiative that has kind of advanced into this new, basically the new Framingham, but is now throughout the US. And very recently, we compared to the US Census and showed that, at minimum, they're largely following the US Census, which still does mean, primarily European ancestry, but they are uniquely enriched in African Americans or Black Americans but underrepresented in many other populations, including Asians, East Asians, and South Asians. So we kind of developed our own remote biobank to help with the enrichment for South Asians and a kind of a complementary biobank. So I encourage you to share this information with patients. It is all largely remote. But, one can use methodologic innovations to really help with the overall performance of these scores, but also their portability across different populations. This is one effort here where we've taken information for the genetics for different populations, but also the genetics of different risk factors. Because kind of related to what I talked about FH, where I said, genetic alleles that promote cholesterol give more additional information for cardiovascular disease beyond the LDL cholesterol. Turns out that's also true for common genetic variation that we analyze in genome-wide association studies, meaning a polygenic risk score for LDL cholesterol has greater risk, confers greater risk for cardiovascular disease beyond just the LDL cholesterol. So we can actually take all of that information and also further boost our risk classifier. So, here's a comparison benchmarking to an older score that we had that was popularized because it showed that there were actually many individuals at very high risk for disease that was only detectable by polygenic risk score. And now with the same information, it's not like the genotypes have changed. It's just our understanding of the genotypes have evolved, and there have been more methodologic innovations that we can say for that same group of individuals in the top 20th percentile, so high genetic risk, so 1 in 5 individuals now have a 3-fold risk for cardiovascular disease by high polygenic risk score. Now you contrast that with FH. So FH variants also have about a 3-fold risk compared to the average in the population. And it's only 1 in 300 individuals. That's like 0.5%. This is 5%. This is two orders of magnitude greater for the number of individuals that you would detect. And you can get to individuals at very high extreme risk that don't have a negligible fraction just because these scores now explain more of the distribution or variation for cardiovascular disease risk. And as you can see, the performance is increasingly improving across populations. Now, uniform observation across all polygenic risk scores is even with more and more training information, individuals of African ancestry continue to have lower performance for these scores. There is it is predictive, but it is less so. And there are many different reasons why that might be the case. And, I have various hypotheses out there, but I think this highlights that there likely are more important non-genetic factors that are likely driving this risk or intersecting with risk. But, we need this information if we're going to use them in the clinic and then contextualize its reporting. And actually, when these scores are reported, they're using genetic ancestry to have a more accurate representation of what the risk actually is, as opposed to just assuming the risk would be the same across populations. Now, this study is, almost 10 years old, 8 years old, where colleagues at the Mayo Clinic using an older score now started to introduce this in the clinic in a randomized controlled trial. And they took the individuals at borderline intermediate risk and did a couple things. One was just purely communicate risk, and they communicated risk for everybody based on their clinical risk. And most of these patients, nobody had really done that yet for them. And then for half of them, they also gave them their genetic risk. So a couple observations. One, when you communicate risk with anybody, that leads to lower LDL cholesterol, maybe through pharmacologic means, non-pharmacologic means. And if patients and clinicians are told that the patients have high genetic risk, that leads to even lower LDL cholesterol. And you might say, okay, that's great. Anybody who has LDL cholesterol lowered, they're going to improve their cardiovascular disease prognosis. However, when we have gone back to completed randomized controlled trial data, we find that individuals at high polygenic risk score benefit even more from cholesterol lowering. This is similar to that FH observation, although those were retrospective observational data. We find here that there's a greater relative risk reduction for the same amount of LDL cholesterol lowering. Now, again, individuals who have diabetes, smokers, hypertensive, features that we help us identify who should be on a statin, their relative risk reduction is the same, about 20 to 25%. The reason why we prescribe statins for them is that they just have higher absolute risk Okay, so if the absolute risk is high, but the relative risk reduction is exactly the same, the absolute risk reduction will increase just because you're starting at higher absolute risk, which narrows the number needed to treat. However, with the high polygenic risk score, you're starting out at high absolute risk because it's independently predicting cardiovascular disease, but there's a greater relative risk reduction. This further magnifies the absolute risk reduction, and that continues to narrow the number needed to treat. Because in the end, like, C statistics, odds ratios are all great, but we're in the business of not just prognosing. We're in the business of trying to figure out what can we do to ultimately lower risk? What is the therapeutic plan? And something that makes the most sense for that patient, or they're more likely to benefit. And so in addition to helping us with prognosis, this is actually a really important feature to helping us identify who is actually going to benefit from a statin in the primary prevention setting. Now, this is not just specific to statins. This unique interaction has been described also for PCSK9 monoclonal antibodies. So there's some important interaction with LDL cholesterol lowering, and there are various hypotheses on why that's the case, because these scores were not trained on this interaction. This has just empirically been observed. Now, for recurrent events, we don't have great scores to help us predict who is likely to get a recurrent cardiovascular disease risk. And we recently asked to see, how does a polygenic risk score stack? Because the polygenic risk score was abnormal for people if it's abnormal well before the event. Does it have any relevance after an event? And if you take all the traditional risk factors and you put them together and you put a bunch of other, non-clinical factors and emerging factors, we were really surprised that in that overall model, polygenic risk score was the top in importance. And you'll say, okay, why is LDL cholesterol down there? I don't believe this. And that's because, when patients get cardiovascular disease, we are all pretty good at constraining their traditional risk factors down to normal or less than normal. So in the population, they actually don't become great predictors for recurrent cardiovascular disease events. And these other things do seem to play a role. Now, what does that mean in clinical practice? Maybe, as we get more and more expensive medicines and you drive cholesterol vanishingly low, maybe certain factors can help us understand where that makes sense. But this is still a little bit in the research space. And we've talked a little bit about clinical trial designs and enriching clinical trials to help us inform how this might be used in secondary prevention. But really, most of this, I think people are thinking about clinically in the near term, still on the primary prevention side. Okay, so, where the research infrastructure has been historically has been in middle-aged individuals followed for a certain amount of time. And that's it's the research infrastructure that is, well adept to look at 10-year risk. And so most of what the assessment of the performance of polygenic risk scores has been where clinical risk factors are most optimal. They are trained on this data. As I said, age and sex are great. So it's actually really hard to improve beyond age and sex, let alone additional risk factors that are modestly improving. The unique feature for polygenic risk scores is that these things are available at conception or very early in life for an opportunity for improved lifetime prevention for cardiovascular disease. And this is not a novel concept. This was just last year, less than a year ago, where people are excited or enthusiastic about the prospect of these kinds of tools to help us prevent, events that happen early in life, because premature events, those are often before middle age or early middle age. Those individuals all have low 10-year risk because they are younger. Right, so maybe these tools can really help us identify these. What are the tools that we have today for early events? Because as I said, 10-year risk is not sufficient. We do have screening lipids, and screening lipids are great. Problem I said is that not that many individuals have severe hypercholesterolemia that you're going to start some medicine, right? So this score, if you're thinking about screening for individuals who are very high risk early in life, you actually are even more efficient, more individuals with the same risk by doing a high polygenic risk score. And this is where I think the future is. It does, when you're invoking screening and therapies in large populations of young, healthy people and potentially interventions, this is where trials and feasibility, all that stuff is still really important. That still needs to be done. Because if you look at the events that are happening, especially the premature events, as I said, are not well captured by clinical risk scores. So this is the pooled cohort equations. and the AUC on how it is more optimal later in middle age as opposed to later or earlier. And a polygenic risk score is better at predicting the earlier events and decays over time. It becomes less relevant over time for individuals who continue to be free of cardiovascular disease, largely because of other factors that have overcome any genetic influence. And so it doesn't need to be an either or. Actually, if you put these together, you do have much greater harmonization over time for the prediction for cardiovascular disease events. But in the end, ultimately that's 10-year risk. These are, new models that we've been exploring for better prediction of lifetime risk, looking at the trajectory of clinical risk factors as well as the baseline genetics that I think ultimately we'd like to get to, of saying, okay, these are the folks we want to invest resources early in life because they have future high premature and lifetime risk for cardiovascular disease, and now provide the tools to identify those individuals. And why is it important to identify individuals early in life is that for things like LDL cholesterol lowering, it's not the same relative risk over time. I kept presenting overall mean effects. This is one of my favorite papers. And this is not a genetic paper. If you look at individuals who are in statin clinical trials, for every year they're in the trial, the hazard ratio continues to decrease. The relative benefit of being on a statin, even just over the 5-6 years, continues to increase. And this is extrapolated to based on human genetic lifelong lowering. This is just sort of a reprisal just in more diverse populations. But as you can see, for high-risk individuals, not only in identifying the high-benefit individuals, the high-benefit individuals are more likely to benefit even more when you do it earlier in life. Because in the end, again, we want to find the right therapy for the right patient and be able to communicate with them that they're more likely to benefit. Because even just taking a step back, like people like Rob and others in the audience who do primary prevention, these are asymptomatic individuals. And if you're going to introduce some therapeutic intervention and let's say they don't go on to have an event, either the medicine worked or it didn't work, it's not going to make them feel any better, but they have to buy into the notion that they're going to benefit, because you would never know the truth, right? So it very much is using the literature and using the data to help with that risk communication. And these kinds of data are important for that, because it really is not just another risk factor. And in the end, this is a population-based study in Finland where they asked about 5,000 or 6,000 individuals, and they communicated their risk. They asked them about the importance, and many of the people felt like genetic factors were important, implying that they could be a powerful motivating tool. That has always been one of the promises of communicating genetic information. And they looked back and said, okay, in the single arm, among the people where it's communicated and what happened later on, especially if there was lifestyle improvement, the amount of clinical risk was a predictor of how much people were going to optimize their lifestyles. And independently, the amount of abnormality, the higher individuals had a more abnormal genetic risk, the more likely that they were going to have lifestyle modification. And there aren't that many cohorts out there to look at, essentially lifetime risk for younger individuals. The NHLBI cardiac cohort is one, and as you can see, most of these individuals don't have abnormal risk factors that you can have powerful discrimination very early in life with polygenic risk scoring. We're starting to use this in the clinic. This is actually in the context of a research study, although there are third-party vendors out there that where you can order the score. These are distributions, for individuals with FH versus without FH. But most of the individuals where we're thinking about ordering this, oftentimes family history is a major reason that people come in, they tend to have higher polygenic risk scores. For most of the folks who were ordering the test, we were doing something different after getting this information. Sometimes it's helping us in deciding whether these individuals are starting a statin. They're often younger individuals. They're unlikely to have abnormal coronary artery calcium scores, for example. It may help with intensifying the statin. And for some individuals, it's still at an appropriate age where we do consider imaging. Again, these are not either or opportunities. We use all the tools in our armament. And we are working on developing basically the ability to do these scores in-house. This is a pipeline that we've developed really for a project at the VA. Okay, so just to wrap up, so we have time for questions. So, polygenic risk score is a unique biomarker in that it only needs to be done once. The genotyping needs to only be done once. As I said, for the same genotypes, the scores are evolving. We have not yet reached an asymptote where we can say that we're the best or close to the best we're ever going to get for a polygenic risk score. As we do larger and larger and more diverse genome-wide association studies, the performance of the scores are continuing to go up. So I think importantly, when you read the literature, and this is pretty rapid, is that many of those same observations really need to be revised using the newer scores. And that's different, right? Like you get lipids or lipids, coronary artery calcium score is a coronary artery score. As I said, so as we continue to profile more individuals, we'll learn more about coronary artery disease, but we'll also learn more about polygenic risk scoring. And then uniquely, we can use this to identify individuals early in life who are going to have greater lifetime benefit from interventions, who are at risk for premature events and just overall greater events. And then in the end, I think all of this boils down to thinking about actionability and risk communication, which is, I think, an important nuance, but it has emerged that genetics can be a very powerful tool in that aspect. There are lots of people to thank. There are lots of collaborators that kind of are involved in all of the studies and many of the other studies that I haven't shown today, but importantly, the folks in my lab who do all the hard work, many of whom have contributed to the work that I showed. Okay, I'll stop my screen share so you can do the CME whenever appropriate, but open for questions.
Thank you very much. That was an amazing lecture. So if anyone has questions, please put them in the Q&A and we'll go through them. I'll start with two questions, as there are no questions there. Obviously, when you look at these polygenic risk scores at middle age, you will miss the younger ones that are maybe higher risk, so they already had an MI. Do we have enough data as to use it in younger patients under 40 years of age, or we need to acquire more? And the second question is, we also don't take into account epigenetic modifications with the polygenic risk score, right? What do you think about these methylation risk scores or these newer scores coming up?
Yeah, so two questions. So one, do we have enough data to use these data early in life? I think there's enough information to use it at middle age too, right? Because I think there's a nice paradigm, at least as it relates to risk enhancing factors. The greater opportunity or the greater likelihood of benefit for the patient and overall for the prevention for cardiovascular disease is if we are primarily doing it in younger individuals, because younger individuals often don't yet have the abnormal risk factors that will put them at risk. And for many of them, this is the driving risk factor. It turns out there's actually a lot of people where this is the driving risk factor, particularly for the premature events. So I think we need to be doing it in younger individuals. The family history clues us in where at least maybe the clinician will buy into it, the patient will buy into it. Most of the times, at least in my practice, there isn't a tractable risk factor. Otherwise, they probably wouldn't be seeing preventive cardiology. That might be why there's a bias towards an enrichment in the diagnostic yield. But I think that can be one of the things that one checks. Oftentimes today, people check lipoprotein (a), for example. We recently had the Little Jack Advances research letter to show that lipoprotein (a) is one of the features in a polygenic risk score, but it's actually a very, very minor feature. So the two are not really that strongly correlated, and they are independent features. But again, as I said, like the diagnostic yield, you're more likely to find an abnormal test result with the polygenic risk score than lipoprotein (a) or LDL cholesterol. I'm not arguing against that, but I'm just saying, just for comparison, that actually would be a more useful test to run. And so, I don't endorse any specific company. There's this one company that we just happen to work with. I think I connected somebody at Sinai with this, but Allelica is the name of the company, and the scores, it's their own proprietary score, but works pretty well because they published on many of the data sets. So we have evaluated scores, and they communicate, I think, in a responsible way that one can start to do this. Because so far, no insurer is paying for it. It's out of pocket, at least for that company. It's $250 out of pocket. It's kind of like early days of coronary artery calcium scoring. So I think we should increasingly primarily use it in younger individuals. And then you had also highlighted other features, especially genomic features like epigenetics, which are very strongly correlated with risk. Well-validated epigenetic or methylation clocks that have been correlated with mortality and cardiovascular disease. And this is kind of the flavor of many things that have been, that are age-related or even not age-related, that are strongly influencing cardiovascular disease, that are all very promising. The one thing I'll say just about the genetics is that the genetics is already permeated like the world and the US among our patients. It is already there. That's the unique opportunity here. And it's possible that over time, all of these other features, as they become more scalable and are implemented at minimum in research settings, that these can also be opportunistic features. But by no means, this is not the only way. Like we actually had this study where, with, like, for example, with whole genome sequencing, at least with genetic variants, there are many different things that you can get together, right? For a true genetic test, there's polygenic risk score, there's, Mendelian variants like familial hypercholesterolemia. That's not there in array, but whole genome sequencing will get that. From whole genome sequencing, you can actually extrapolate telomere length, leukocyte telomere length, separately associated with cardiovascular disease. As you talked about in the introduction, we've looked at somatic mutations. From blood-based whole genome sequencing, you can also get the somatic mutations. So you can actually get all of that information together and build an even better genetic classifier. And I think the tools will continue to evolve that will find not only other genomic features, that maybe these other genomic things like epigenetics and others may start to be part of this sort of more comprehensive molecular profiling. People are now looking at proteomic scores and metabolomic scores. Those are things that are likely things that you would, if you're implementing, you have to figure out what is the serial opportunity, at what time do you do it. With the genetics, it's kind of easier because it's a one-time, you're never going to repeat it. But yeah, sorry, long-winded way of saying, I think all of these things are promising. It's just the where things are right now in precision medicine and the data that is being generated and the data that our patients are going out and generating themselves that's available has right now been on germline genetics.
Oh, thank you very much. I think it's for those of us that do prevention and use imaging, clearly, imaging in younger patients can be challenging because of radiation, because of calcified plaque that may not be there. And you obviously can't do, massive, or we're not considering as of yet doing screening everyone with imaging. It seems very hard. So we're all waiting for this. So we should be using them more.
Yeah, I mean, I feel like in an ideal world, we will identify the right patients for an intervention before they developed any atherosclerosis, right? Because once they develop atherosclerosis, their risk escalates. And so this is one of the reasons why so far in the guidelines, even though coronary artery calcium score is a stratifier for individuals when they have FH, we know that there is a powerful abnormal risk factor that is abnormal for these individuals that, if you identify it early, then you'll substantially improve their prognosis. And why wait until now that they are a high-risk individual? And so in the guidelines, we are, level 3 recommendation. We don't recommend subclinical atherosclerosis. And I feel like in an ideal world, like we would appreciate this as a similar paradigm, a powerful early in life predisposing factor to atherosclerosis. And if we can interrupt that process, then we maintain, population level risk or lower for these patients.
Yeah, 100%. And just going to that with one more question. Is there any difference between the initiation of CAD and the progression from the genomic aspects, or anything you can comment on that we know already?
So, I mean, as I said, there's at least, there haven't been that many studies in recurrent events. Like, what the study that I showed earlier for recurrent events was in the UK Biobank. And what we have is just the granularity as far as like ICD codes. And you have to do a lot of additional analyses to make sure it's people not just recurrently coding the same event. So we know at least when they're getting a recurrent event, it is happening sooner when they have a high polygenic risk score. Separately, it's been described by us and others that when individuals have a high polygenic risk score, it's associated with a greater burden of atherosclerosis. They have higher coronary artery calcium scores. Whether that means they have more severe cardiovascular disease or multivessel cardiovascular disease, that still requires further study. There are a number of people that are working on it. The main challenge is, what is the research infrastructure? Most of the research infrastructure that is outside the clinical setting, so you don't introduce biases, have been cardiac CTs in asymptomatic patients. However, now there have been more and more data sets in secondary prevention, where people have funded and generated genetic data to look at recurrent events, to look at the imaging characteristics, look at the procedural characteristics, to help us understand why there is greater recurrent risk. So it's different. So it appears to be clear that they have different events and that they are higher risk for recurrent events, but we still need to study. We still don't know.
Yeah. No, thank you very much. So a lot to come, hopefully, and we know it's gonna be a lot coming from your lab. So at least
and many others. I mean, lots of people are thinking about this, but it's an exciting time. Always looking for collaborators. So reach out.
great. So thank you very much for your time. This was